Welcome back. In this session of lipid health concerns, what we're going to mainly focus on is the formation of plaque in your coronary arteries, specifically that leads to some issues with heart disease. So we're going to deal with that, and then in part two, we'll look at the nutritional aspects of what can increase the risk of plaque formation for this. So let's get going. Is the lack of blood flow through the coronary arteries. If you don't know, the coronary arteries are the blood vessels that feed the heart muscle. So if we have a deficiency in blood flow, then we are going to have a lack of oxygen, we're going to have a lack of nutrients, and those heart muscle cells will die, and we will call that a heart attack because they will quit functioning. So the main thing is coronary heart disease, which is inadequate oxygen supplied to the heart muscle or the myocardium. And in nutrition, the main concern would be the plaque formation in those coronary arteries that are going to narrow the blood vessel and reduce the amount of blood flow. So you can see here that heart disease death rates in 2013 to 2015, uh, and you can tell where you don't want to move to. You wouldn't want to move to this area. Uh, the food is too good. There is, they eat pretty good down there, but they don't, and not necessarily eating salads. Um, anyway, this is it looks like Oregon is not doing too bad up in here. We're up in the lower range per 100,000. But anyway, but heart disease is the biggest killer in the country. So uh, let's talk a little bit more about it. The main risk factor for heart disease is hypercholesterolemia, which basically means high cholesterol in the blood. Well, based on our talk about lipoproteins, you'll remember that LDLs have the highest percentage of cholesterol. So when we talk about hypercholesterolemia, we're basically referring to high LDL numbers. And high LDL numbers are what are of a concern for depositing plaque in the blood vessels underneath the intima, or the inside endothelium of the blood vessel, and narrowing that artery. So the risk factors are the high cholesterol levels, and so in nutrition, our goal is to reduce those cholesterol levels. So what things can be done to reduce hypercholesterolemia? Well, as far as diet is concerned, you would think that eating cholesterol would increase your cholesterol, but it really doesn't that much. The last information I got, that if you ate the same diet that you always did, but increased your cholesterol by 100 milligrams, so the goal is 300 in dietary intake, and if you increase by 100 milligrams, it may increase your cholesterol, over a long period of time by about 4%. So it's not a huge player in increasing your cholesterol level. That's why eggs are now uh, not as bad as they used to be. When I was going to school, eggs were definitely a no-no. You shouldn't eat. They're high in cholesterol, that kind of thing. But eggs are good food, so they're in the cholesterol that's in them is not that major of a factor. Now, if you have heart disease and have a real risk factor for heart disease, then you need to limit your eggs, but not completely eliminate them. Um, Saturated fats seem to be the key problem. Saturated fats tend to have the highest effect on raising blood cholesterol levels. Along, I should put in there also the trans fats are going to increase risk of the hypercholesterolemia. And then total calories is also, if you remember in the lipoproteins, we said that when the liver gets high in fat, it will make a VLDL to get rid of that fat. And then if you remember, we said that the VLDLs will lose their triglycerides and become IDLs. And then 2/3 of the IDLs will be taken up, but 1/3 of them can become LDLs. We also have talked about in the past that, you know, everything you eat, basically, whether it's protein, whether it's carbohydrate, whether it's fat, when it gets to the liver, you know, is going to become fat if you have excess. So if you think about it, if you eat too much bread or eat too much meat and it gets to the liver, then that liver is going to change that into fat, which increases the fat of the liver, which basically means that you'll have to increase the number of VLDLs that are produced. And then if you do that, then obviously those VLDLs become IDLs to LDLs. So you can increase your LDL numbers by eating too much bread or eating too much meat, kind of a thing. So total calories can also increase your LDL numbers, which would increase hypercholesterolemia. Soluble fiber has an effect. As you remember, it is going to take out dietary cholesterol to some extent. It's going to bind onto that cholesterol and take it out in your waste. But it doesn't work for everyone. Because if you look down at the bottom, it says endogenous synthesis. Well, what that means is that the liver is able to make its own cholesterol. If for whatever reason the liver is not taking up as much cholesterol that's in the bloodstream from like the diet, then it can make its own to keep and maintain homeostasis or to be used to make hormones and to make bile and all that kind of stuff. So in some cases, you know, some people diet is the issue with high cholesterol. In some people, it's not the issue with cholesterol. If you remember, oatmeal was high in soluble fiber. So there are some individuals, you know, that's one of the first recommendations a doctor might say is to, you know, eat oatmeal, lose weight, whatever. But for some people, you know, everybody has a different homeostasis of LDLs in the blood, and so the liver's job, one of its main jobs, is to monitor that. And if it gets high or low, then it's going to do something about it. So in some cases, it could be diet for some people, but in other people, it may be, you know, they don't eat a lot of cholesterol or so forth, but their LDLs go down. So the liver says, I'm just going to make some more cholesterol, make some VLDLs, and make some more LDLs. So it works for some people it doesn't work. Then absorption rate, there is you know, some people absorb 25% of the cholesterol they eat and saturated fat stuff. Some people only 75%. So there's a 25%, 75% ratio of how efficient some people are. So that can be a dependent factor on hypercholesterolemia. I want to introduce metabolic syndrome. Metabolic syndrome is, well, I think we talked about it. We may have talked about it before. I may have introduced it before, but metabolic syndrome is a condition that physicians will use, in this case for cardiovascular disease, if your LDL numbers are low. But your metabolic syndrome factors, which basically is that you need 3 of these factors to be diagnosed as having metabolic syndrome, then if they're diagnosed with 3 of those, then that's just as high of a risk factor as high LDLs. So visceral obesity, atherogenic dyslipidemia, including elevated triglycerides. We've talked a little bit about that in relationship to women. Small dense LDL particles. We'll talk about the small dense ones in a bit. Low HDL cholesterol, which is the good cholesterol, high blood pressure, and insulin resistance. Those are all risk factors for metabolic syndrome. So again, once again, the factor is if you have 3 of these, then you have been diagnosed with metabolic syndrome, which is a diagnosis that's now presented. So when you start working in the hospital, you'll be under the auspices of the accreditation authority with the hospitals, and they will come and inspect your hospital, and the hospital will go through a series of well, the team will inspect everything from, the kitchen all the way up to the patient's charts. And for each disease, there is a primary and a secondary target. And that's the protocol. So that in this example, if somebody comes in with heart disease, the primary protocol is to check, and make sure their LDL numbers are within the parameters. And if they're not, then the goal is to do whatever it takes to try to get them down there. Now, that doesn't mean the patient has to reach those goals because, everybody's different. But what the team will be checking for is, did you do whatever was possible, medically sound and possible, to get their LDL numbers down? So that means, with drugs, or for the dietitian, that means, did you counsel them on how to reduce their LDLs through diet? Did you explain that? Did you explain weight loss if that's necessary? Did you explain, soluble fibers and everything? And give them instructions on a meal plan and all that. And for the physician, did you prescribe statins or something like that? Did you try to get it down? So, the goal is less than 100 milligrams per deciliter, but once again, the accreditation team isn't there to say you have to get everybody down there, because that's impossible. So they'll make sure that you've done everything medically possible to get them down to that level. So the primary target for patients with heart disease risk is to monitor LDLs and make sure that you try to get them down to below 100 milligrams. So the liver, one of the liver's jobs is to, as I mentioned, is to monitor LDL numbers, and if the homeostasis is really high, they go through a process of phagocytizing those, or going through endocytosis, and they will take in the LDL particles and they will break them down. So therefore, you're reducing the amount of LDLs in the blood. So as you can see on this diagram, these protein markers are the apolipoproteins that we introduced in the lipoprotein section. And then you have receptors. So this is referred to as receptor-mediated endocytosis, so that the identification markers will match up with the receptors, and the liver will take those LDLs in and reduce the number in the bloodstream. So we're going to go ahead and we're going to spend some time looking at this whole process, but where we're heading is to show you in basically the second part of this session is to look at how diet can affect the ability of the liver to maintain homeostasis. So there are three pathways that we're going to talk about that would be ways to remove LDL from the blood. We're going to go over the cell receptor pathway, the liver receptor pathway, and then the bad one, which is the scavenger pathway. So let's start with the cell receptor pathway, and this is the normal process of cells getting cholesterol. Cells need cholesterol. If you remember, plasma membranes of animals have cholesterol in them. So if you're going through cell division, making new cell membranes and stuff, then you need cholesterol. For making hormones and different reasons like that. So cholesterol is a good thing. It's necessary in our bodies. We have to have it to live. It's just that if it gets in wrong structural properties, then it becomes a problem. So the process is the LDL is going to be absorbed by attaching to the receptors, so on the identification to the markers to the receptors, and then the cell will phagocytize it, go through mediated endocytosis, and take that and break down the LDL and utilize the cholesterol and everything else that's in there. The liver receptor pathway is the pathway by which the liver is going to monitor the homeostasis of the LDLs in the blood. So it is going to monitor it. If the levels are too high, then it is going to add receptors. If you remember from the diabetes session, we said that the cells can add or delete proteins as needed. And so in this case, the same applies to the receptors in the membrane of the liver, is that if the homeostasis is really high, then it can add receptors so that it will take more LDL out. If the LDLs are fine, then you're going to reduce the receptors in the membrane, and so you won't take as many out. So it's going to maintain homeostasis, but it's also going to be able to utilize that cholesterol for liver function. And so here's a liver cell that I want you to really get down. We're going to go into be very specific in this unit, looking at this cell. This is one liver cell that you're looking at, and looking at the process of how LDLs are taken out, and then what happens inside of the liver cell if it has excess cholesterol. And then in the second session of this, part 2, we'll go into how nutrition plays a role in this. So first of all, I want to go through and just talk about the whole process of how LDLs are removed from the blood and they get into the liver cell, and then what happens inside the liver cell. So in the normal process, basically, the liver is going to monitor the blood levels of LDLs. Uh, and so as I mentioned, number 2, the liver is going to add LDL receptors if it's too high. The ApoB100 markers, if you remember, are the markers, the identification markers on the LDL. And so those markers are going to match up with the receptors, and the liver is going to bring that in by phagocytosis. Lysosome is going to break it down. The contents are then released, and they are then usable. And cholesterol will be deesterified to free cholesterol. And so we'll talk about that in a second. And free cholesterol and LDL contents are usable by the cell. Okay, so let's look at the picture of that. So you'll notice up at the top we have high blood LDLs, and so the LDLs then are needed to be taken out of the blood to maintain homeostasis. So you'll notice that on the plasma membrane of the liver you have the LDL receptors. So the identification markers, the apolipoprotein B100 or ApoB100s, are going to match up with the receptors on the plasma membrane, and you'll notice that the membrane is engulfing that LDL and bringing it into the cell. Then you'll notice that the lysosome is starting to break that LDL apart, and you'll see it's breaking apart the protein parts into amino acids, and then it's going to release the cholesterols. But the other thing that you'll notice is, if you remember in the lipoprotein section, we said that when cholesterol is being transported, it is transported in the form of a cholesterol ester. So you'll notice up at the top, when it where it says that high blood LDL, you'll see it says cholesterol esters. And if you remember, the ester part is a fatty acid. So you'll see there's a little tail on the cholesterol, and that tail is the fatty acid. Okay. Well, one of the things that's going to happen, part of the lysosome piece, is that the fatty acid is going to be removed, which basically is referred to as deesterification. And because the linkage between the fatty acid and the cholesterol piece is an ester linkage, so deesterification means that you take the little tail off. So what you'll notice is now we have cholesterol without the little tails, or they are deesterified, and they're referred to now as being free cholesterol. And that free cholesterol is usable cholesterol. And so you can see as the arrow goes to the right that these cholesterols now can be used for cell membranes, for steroid hormones, for bile acids, so they're usable. When they're in the form of cholesterol esters, they're not usable. They're cholesterol esters when they're being transported or when they're being stored. So this free cholesterol is now usable. Okay. But at a certain point, obviously, the liver cell can only take in so many LDLs because they get filled with free cholesterol. And so when you get these high levels of cholesterol, then some things are going to be turned on and things are going to be turned off. And so we're going to be looking at these enzyme complexes that are going to be turned on and turned off, so that ultimately you'll have a suppression of the LDL receptors. You'll remove those receptors from the membrane and reduce the amount of LDLs you bring in, because you don't want to add any more free cholesterol to the liver cell. It's full, right? So therefore, you would not bring any more LDLs out of the bloodstream, and so that number is going to stay stable there. So here you see the free cholesterol, and then you go to here where it says an oversupply of cholesterol, but you'll see those numbers, number 1, number 2 on the bottom, and then number 3 on the left-hand side, of what's going to happen whenever you get an excess of free cholesterol. And what's going to happen is you'll notice that the synthesis of cholesterol, remember we said the liver cells can synthesize, that was the endogenous synthesis, they can synthesize their own cholesterol using the HMG-CoA reductase enzyme system. But you'll notice the arrow indicates that if you have an oversupply, obviously the liver doesn't want to make any more of its own, doesn't have to, so you inhibit the ability of the HMG-CoA reductase to work, and you won't make any more free cholesterol. Then I want you to know this ACAT system, and you'll notice it says activate. So you're going to activate the ACAT system, and what you'll notice that ACAT system is doing is taking that free cholesterol and re-esterifying it. You notice that in the bottom of that red box where it says storage of cholesterol esters, that the cholesterol now has little tails on it, or basically what's happened is you've added fatty acids to those cholesterol and re-esterified them for storage. again, cholesterol esters for transportation and for storage. So they're going to store them and eventually probably be put into a VLDL and removed from the liver cell if there's an oversupply. The other thing that's going to be inhibited, as you notice, and hopefully you've had some cell biology and understand the idea of transcription, translation, going to the ribosome with the messenger RNA, going to the rough ER, Golgi apparatus or Golgi body, and then making protein substances. Well, in this case, you'll see that what you're making is LDL receptors. Well, if you want to reduce the amount of LDLs you bring in, obviously you don't want to make any more receptors. So it's going to inhibit the process of making receptors. And it's also going to remove the LDL receptors that it has on the membrane. So you're going to reduce the amount of LDLs you bring into the liver cell. Now later on in the second session, we'll talk about how nutrition and some nutrients can affect this pathway. So this is the liver receptor pathway. And so you'll notice the big X means you're not bringing any more in. There is a genetic condition that in some cases doesn't allow the individual to make receptors, and this is called familial hypercholesterolemia or familial cholesterolemia. And it's a genetic disorder that reduces the amount of LDL receptors that a person can make. So in this case, this would be an individual that have a hard time getting LDLs out of their blood. But what I'm going to tell you right now, and where we're kind of heading, is that having high LDLs is not a death sentence. It only is a risk factor if those LDLs become oxidized. And we've talked about oxidation when we talked about chronic inflammation. So we'll talk about it a little bit more in connection with this. But anyway, they would have a hard time getting LDLs out of their blood. But if they're not oxidized, they're not a problem. But still, as far as medicine is concerned, if you have high LDLs, then you're at high risk because they don't really know if they are oxidized or not. But the way that our lifestyles are, they make that assumption that they are oxidized. It's kind of like you cook canned green beans hot enough to kill Clostridium botulinum. You don't really know if Clostridium's in the beans, but you heat it enough anyway to make sure that if they are there, they're going to be destroyed. Same thing, if you have high LDLs, they're going to try to get them down and do whatever they can because the assumption is that they are probably oxidized, but they don't really know that. Someday maybe there'll be a simple inexpensive tests that they can do that, but right now they can't. So I wanted to talk a little bit about, excuse me, Lipitor, and because it has a direct relationship to this in the liver cell. I know this is probably hard to read, but let me read the underlying parts. It basically says it's a competitive inhibitor of HMG-CoA reductase. And I'll show you the picture and remind you what that is, but that's the enzyme complex that's needed to synthesize the liver's own cholesterol. But it's going to inhibit that. It's going to fit into the active site of that enzyme and not allow it to do its function of making cholesterol. Well, in the process of doing that, though, it's going to increase the number of hepatic LDL receptors on the cell surface because the liver, if it can't make its own cholesterol, is going to want to bring LDLs in to get more cholesterol. And so it is going to reduce the cholesterol, LDL in the blood. So let's look at that picture. And so here you see Lipitor, and you see the picture, and here's where the HMG-CoA reductase is, where it allows the synthesis of cholesterol into free cholesterol there. But if you eliminate that ability, then what's going to happen is you're going to have low free cholesterol, and it's going to have the opposite effect of an oversupply of cholesterol, and it's going to activate this transcription translation of synthesis of LDL receptors, and it's going to make more LDL receptors. Therefore, you're going to increase the number of LDLs taken out of the blood. So what Lipitor does is just force the liver cells to make more receptors to take more LDLs out of the blood. And that's the reason that, if you're on Lipitor or any of the statin drugs, they do liver tests to make sure that you're not screwing up the liver somehow. And there are some markers that are produced that can indicate stressing the liver, and maybe they might try another statin for you or something like that. But that's the whole purpose of Lipitor, is just to cause the liver cell to make more LDL receptors. Now, the scavenger pathway is the bad one. This is the one that is going to lead to plaque formation. But the scavenger pathway is only going to result if the LDLs are oxidized. We talked a little bit about the oxidation of lipids in the chronic inflammation piece. And so that can lead to a modification of the identification marker, and that's where we're heading. That is going to cause the macrophages, or white blood cells, to engulf them and eventually become plaque. Because this oxidized LDL, as you see under purpose, is going to be considered a foreign particle by the body. And we'll talk about why here in just a sec. So if you read the red part, now you can, in your PowerPoints, you can read the rest, but basically we're looking at small, dense LDLs, and they're going to be a modification that is going to change the ApoB100 marker. So remember that in your body you have identification markers on your cells that your body knows that those are yours. That's how it identifies, like a virus or a bacteria, is they don't have the identification markers that are normal, and so they will attack it. So if you modify this identification marker, then the body's going to think that's a foreign particle and try to get rid of it by engulfing it. And so the scavenger cells would detect this change and engulf those modified LDLs and eventually become foam cells and plaque. So let's go in and look at how that process works. If you remember, in the lipoprotein section, we mentioned that there are different sizes of LDLs. And what's the information that I've read is that the small LDLs tend to be of a bigger issue for plaque formation than the large LDLs. That doesn't mean that the large LDLs can't be oxidized and increase chronic inflammation. They can, but we're talking about plaque formation. And so the small LDLs are going to have a bigger impact on plaque formation than the large, what they call large buoyant LDLs. That's why when we were talking about metabolic syndrome, if you remember, one of the categories was small, dense LDLs as part of the metabolic syndrome. So in atherosclerosis, basically the process that's going to lead to plaque formation is LDL oxidation. And so the cause would be free radicals, or the oxygen radicals, or what we refer to as reactive oxygen species, and leading to oxidative stress. So if you remember from the definition, it's an imbalance of reactive oxygen species to antioxidants and those that can take care of that reactive oxygen species. So there's an imbalance there, and if you remember, we had pro-inflammatory mediaries, intermediates, and we had anti-inflammatory intermediates, and looking at the interleukin 1b and interleukin 6, interleukin 8, tumor necrosis factor. All of those would enhance oxidation of these LDLs. So oxidized LDLs, excess free radicals are ROS are the main indicators, or a decrease in antioxidants. So what's going to happen is you're going to have an oxidation of the arterial wall, which is the fatty acids in your phospholipids are going to be oxidized, where you're going to get the hydroperoxides. Remember when we talked about oxidation of the unsaturated, PUFA is polyunsaturated fatty acids. So when you get an oxidation of those and produce that hydroperoxide, if you don't remember what that is, go back into chronic inflammation, and we had a little section on that. And the hydroperoxides are going to break down into aldehydes, and these aldehydes are going to form a shift base, what they call a shift base, specifically with the amino acid lysine on the ApoB100 identification marker. So it's actually one amino acid, the lysine, that is going to be affected by oxidation that changes the identification marker, that is going to increase the immune system, or those scavenger cells. And so the plaque formation is going to come in a series, and I'll show you some PowerPoints to that series, where you start getting endothelial dysfunction, foam cell formation, smooth muscle is going to proliferate, and then you're going to get platelet adhesion aggregation. All of those things are going to start closing off the artery, and causing plaque and that kind of thing. So let's go through. So again, I'll just relate this. If you remember from our topic on chronic inflammation, I'm just going to go through this quickly because you've seen this before, is that you have an unsaturated fatty acid and you loses a hydrogen, and creating a free radical, which can combine with oxygen to make a peroxide, and then that free fatty acid then forms a hydroperoxide by stealing a hydrogen from another fatty acid. So you can have to relate this to the phospholipids of a plasma membrane, or the lipoprotein. I'm sorry, you look at the phospholipid part of the lipoprotein. The fatty acids are going to be oxidized in this same fashion. And so you can see by this process, you get and I don't expect you to remember all these reactions and everything, but here I highlighted the hydroperoxide on the right-hand side, which leads to aldehydes and alkyl radicals and those kinds of things, that are going to then go and cause a change in the identification marker. So let me show you that. As you can see up in the top right hand side, in number 2, you see lipid oxidation, and then you go down and you'll notice it says aldehyde there right below the 2. And then I've kind of highlighted the idea that you take a lysine plus the aldehyde, and then you create this Schiff's base. And then it goes down to the ApoB fragmentation. So you can see that Schiff's base going to change that ApoB identification marker, and you're going to change it into such a way. If you go through the number 4 and then go up to number 5 on the left, you'll notice that the immune system has been activated. And so you get oxidation, oxidized epitopes, and all kinds of things like that. But for our purposes, all you need to know is this is going to change the identification marker to make the LDL be a foreign particle that is going to be attacked, basically. So here you can see the LDL, and it is going to go through oxidation and become an oxidized LDL. You'll change the ApoB100 marker, and it's then going to be recognized by scavenger cells. And the reason the small, dense LDLs are a problem, because again, even the large ones can be oxidized and they can increase the result of chronic inflammation, but we're leading to plaque formation specifically. Basically, it is a concentration dependent thing. If when you're in biology and you talked about diffusion, you might recall that in diffusion, solutes tend to move from an area of high concentration to an area of low concentration to reach an equilibrium. So this is exactly what is happening. Is you have a high amount of small dense LDLs in the bloodstream. There's more there than in the tissues in the blood vessel, and so the small dense LDLs want to move with their concentration gradient into underneath the intima. Well, so do the big ones, the large ones want to too, but they're too big. And so the small ones can move through with their concentration gradient, as you're noticing, and they can get into the intima of the blood vessel. And then if they're oxidized, if they are oxidized LDLs, then what you'll notice, and I'm going to go over this several times in several different ways, but what you can see is this monocyte is coming in, so kind of a glorified white blood cell that becomes what are going to call a scavenger, and it is going to engulf these foreign particles, modified LDLs. By phagocytosis, it's going to form a foam cell, and then ultimately it keeps engulfing these, and it's going to just fill up more and more with these LDLs. But also you're going to get incorporation of muscle cells that kind of help make it hard. And you'll notice that the blood vessel is starting to narrow as this foam cell is getting bigger and bigger. But eventually what I'll show you is this will burst, and then you get that incorporation of the muscle cells, incorporation of some other substances that will make it hard, kind of a thing. So anyway, so this is the four parts of the endothelial dysfunction. You notice the LDLs are coming in, and you'll notice oxidation of the LDL, and the production of ROS. And what's going to happen? These oxidized LDLs, the result is a signal is going to be sent that we have foreign particles. And so you'll notice the monocytes are going to start adhering and so forth, and you activate the endothelial cell, and so there's going to be some action by your immune system because of this oxidation. Then you're going to have these macrophages, or what we call scavengers, are going to start engulfing these LDLs. They have specific receptors that can accept these and start forming a foam cell. So you can see these monocytes are coming in, or scavengers, and you're making a foam cell, but then you start producing these pro-inflammatory cytokines, which is why you are also going to increase chronic inflammation. Remember, the cytokines are what we talked about with chronic inflammation. So they're going to be activated and start sending signals that are going to spur the idea that we have an inflammatory process going on here. Um, so then we start seeing a migration of these muscle cells into this necrotic core, which, eventually, you get the foam cell in there and all the LDLs and all that stuff in there, and you start forming this core inside of underneath the intima of the blood vessel. And then what you see is you have the corporation of muscle, you have this necrotic core, you start having activated platelet adhesion, which basically is going to form a clot. And then eventually it could plug up and you would have a lack of blood flow. So lots of things happening, but you'll notice we have activation of the platelets and everything's going on because of this inflammatory process also, because you're going to bring in the platelets as part of this inflammation, trying to solve the inflammation, but it's not going to be able to do that. So anyway. So this is, again, I'm giving you several pictures to hopefully get it straight, because I know it's a difficult process and to get down. But so anyway, you get this small LDL coming in. We have the modified, or these modified LDLs here coming in. We have the monocyte coming in. You notice the inflammatory mediators being produced, to produce the interleukins and all that kind of stuff. And then you get the receptors that are grabbing these modified LDLs. You start forming a foam cell. You get the plaque, and then the plaque can burst. And then once it bursts, it's hard to remove. We'll see that HDLs, which are the good ones, if you remember good, they can actually remove cholesterol from the foam cell before it bursts. But once it bursts and gets incorporated with the muscle cells and everything, then it's not going to be able to do that. But you'll notice they're talking about ROS, reactive oxygen species, cytokines, tumor necrosis factors, all of those kind of things are going to be produced to increase that chronic inflammation. That's going to affect your whole body and not just here. And so a couple pictures relating to this, again, infiltration of the LDLs in a healthy muscle and creating that inflammatory process to clear the LDLs with the scavengers. And then number three, the plaque containing foam cells. And then you increase that inflammatory process and the plaque will rupture. And then you have basically your plaque. And so you see the plaques just growing and growing and growing and growing. Um, and you can finally just block the blood vessel a lot. Couple statements from some physicians. You'll notice here Dr. Lundell is a heart surgeon, basically says without inflammation, cholesterol would move freely throughout the body. So cholesterol is not an issue unless it's oxidized and creating this inflammation. It's an inflammation becomes trapped. Um, and so this link between chronic inflammation and cardiovascular disease has many healthcare professionals excited about future treatment. So they're going to start treating for the chronic inflammation kind of a thing. And this is just another one. Chronic inflammation lies at the root cause of oxidative damage. And because that chronic inflammation can start damaging other parts of the vessel. And then that becomes a problem. So you see the inflammation, the fibrous plaque. So it's a big issue. So, like I mentioned several times before, you need to really get checked and get your CRP levels checked to make sure. And then, so the plaque is going to be underneath. Here's the intima, the endothelium. It's going to be underneath that intima. So you can't just go in there and scrape it off, kind of a thing. But they can do where they put the balloon in there, and they blow up the balloon. Basically, they can spread out the plaque, and then they put a stent in there, and doesn't allow it to collapse back again and close. And so You can do that. It doesn't get rid of it, but it kind of spreads it out there. So this is basically what it can look like. You can see all the plaque here that is closing off this and making it more narrow and more narrow. All right, so that's your introduction to how plaque is going to be formed, and in part 2, we'll talk about how nutrition plays a role in this whole process. All right, we'll talk to you then later.